Hello, this is Dr. Stanley Kim again. Today we will discuss ovarian cancer. Ovarian cancer is the second most common gynecologic cancer in the US, but it's the leading cause of death from all gynecologic cancers. Why? Because in general, ovarian cancer is an aggressive cancer. But now, by using targeted therapy, we can delay the time of cancer recurrence and possibly improving the survival rates. And also by using upfront chemotherapy instead of traditional upfront surgery, we can reduce the complication rate of upfront surgery without compromising survival rates. Let's discuss more in detail, and thank you for watching. Most ovarian cancers arise from the epithelium of the ovary. Please look at this picture. The ovary has outer lining layer called epithelium. This is the origin of the ovarian cancer, not the inside the meat called the stroma. Epithelial ovarian cancer is closely associated with fallopian tube cancer and the primary peritoneal cancer. So the epithelial ovarian cancer, fallopian tube cancer, and the primary peritoneal carcinoma are considered as one entity and is often called as epithelial ovarian cancer, EOC. About 75% are diagnosed at advanced stages. But the screening of ovarian cancer is not recommended. Why? Because we've done that screening with the CA125 or often ultrasound, but screening didn't reduce the mortality rate. Other than old age, which increased the risk of ovarian cancer and other cancers, the total duration of menstruation, which means total number of ovulation, is strongly related to the risk of ovarian cancer. The longer the duration, in other words, the higher the total number of ovulation, the higher the risk of ovarian cancer. In other words, women who had early menarche or late menopause or never had any pregnancy have a higher number of ovulations, so they have increased risk of ovarian cancer. On the other hand, women who use the oral contraceptives or tubal ligation, breastfeeding, or multiple pregnancy have a lower number of total ovulation, and they have decreased risk. And the later age, over 35 years old, when they have less pregnancy, is factor decreasing the risk. And the genetics and the family history, especially breast cancer gene, BRCA1 and 2, and the Lynch syndrome are strongly associated with increased risk of ovarian cancer. Certain type of ovarian cancer, endometrioid and the mucinous ovarian cancer, is strongly related to the endometriosis. So the endometriosis increased the risk of these types of ovarian cancer. The obesity, polycystic ovary syndrome, IUD, cigarette smoking, or diets are kind of controversial. As I described in the previous slides, most ovarian cancer arises from the epithelium, the outer layer of ovary. Among them, high-grade serous carcinoma is the most common. It's mostly diagnosed at advanced stages and strongly associated with the BRCA oncogene mutation. Endometrioid carcinoma, clear cell carcinoma are less common, but we occasionally see those types. Endometrioid carcinoma is mostly low-grade, but high-grade endometrioid carcinoma is indistinguishable from high-grade serous carcinoma. About 40% of patients with endometrioid carcinoma have a history of endometriosis. And also 15% of them have
endometrial carcinoma as well. Clear cell carcinoma is also associated with the endometriosis and also found in early stages, but advanced clear cell carcinoma has a poor prognosis and usually not sensitive to platinum chemotherapy. They also have an increased risk of DVT or pulmonary embolism thrombosis. Low-grade serous carcinoma is rare. It's a slow-growing, but diagnosed at advanced stages, which means poor prognosis and also relatively platinum insensitive. Mucinous carcinoma is rare, but it's an interesting type of cancer, mostly diagnosed at stage 1, and we think it arises from mucinous borderline tumor, not invading stroma, just outside in the surface. When it was found in both sides of ovaries and in the advanced stages, metastatic disease from GI origin is suspected. So you may have to do the GI investigation to find out the primary tumor arising from some kind of GI origin, like appendix or colon. And they are insensitive to traditional platinum chemotherapy as well. I like to mention about a borderline ovarian neoplasm. It accounts for 15% of all ovarian cancer, and the clinically behaving between benign adenoma and the cancer. There are subtypes like cancer, serous borderline ovarian neoplasm, mucinous borderline ovarian neoplasm, and the endometrioid borderline neoplasm. Today, we're not going to study much about the stromal origin ovarian cancer, like a germ cell tumor or sex cord stromal tumors, like a granulosa cell tumor, Sertoli cell tumors. Those are completely different from this typical ovarian cancer. And also, these tumors are graded as grade 1, 2, 3, depending on their differentiation. The higher the grade, the poorer the prognosis, of course. Patients with ovarian cancer usually have gradually developing symptoms with abdominal pain, pelvic pain, bloating, urinary symptoms, nausea, early satiety, breathing problem from ascites or pleural effusion, abdominal pain due to intestinal obstruction. Adrenal nexal mass can be palpable in the pelvic exam or physical exam. Sometimes they may show a venous thromboembolism. The CA125 is the tumor marker for ovarian cancer, elevated in 80% of ovarian cancer, but in early stage, like stage 1, only 50% of patients will have a positive high CA125 level. Transvaginal ultrasound, as shown in the picture, will show the tumor of the ovary. If CA125 level and the transvaginal ultrasounds are abnormal, then patients need to have a CT scan or MRI of the abdomen and pelvis along with the CT of the chest to see what's going on. Does the tumor spread to somewhere else? If they have ascites or pleural effusion, then paracentesis and the thoracentesis for fluid cytology is necessary. CT-guided or ultrasound-guided omental biopsy or pleural biopsy can establish the diagnosis, but direct biopsy of the ovary is not recommended because you may puncture the cystic malignant cyst spilling over that cancer cells into the pelvis or peritoneal cavity. Once diagnosis of ovarian cancer is made, all patients need to have genetic risk evaluation for BRCA1 and 2 and the Lynch syndrome, because patients who have these genetic mutations can be treated with the target therapy like PARP inhibitors or immunotherapy. Surgery is the mainstay of therapy, and it also established the staging. The surgical staging procedure includes visual assessment of abdominal cavity, peritoneum, bowel mesentery, and other organs, and the biopsy of suspected lesions. Hysterectomy and the bilateral salpingo-oophorectomy, pelvic and the para-aortic lymph node dissection, except the mucinous subtype because most of mucinous subtypes are diagnosed at age stage 1. Omentectomy, infragastric, or complete when you find that cancer in the upper abdomen. Peritoneal washing or ascites for cytology. Appendectomy, it involved, or if it's mucinous ovarian cancer. Try to avoid the tumor ruptures, of course, to prevent the spillage of cancer cells into the peritoneum. Open laparotomy is a standard procedure, but minimally invasive surgery, such as robotic-assisted surgery, may be done by experienced surgeon in early stages only, because it's difficult to do the cytoreductive surgery with the robotic-assisted laparotomy. And now we stage the ovarian cancer. In stage 1, tumor is confined to the ovary, like a 1 ovary, stage 1A, bilateral ovaries, stage 1B. And when the cancer cells are spilled into the peritoneal cavity by ruptured ovarian malignant cyst or positive cytology in the acidic fluid, are categorized as a stage 1C. In stage 2, the tumor is more extensive than stage 1, but still confined into the pelvic cavity. Like a stage 2A, the cancer involves the surface of the or of the fallopian tube or the uterus. And the stage 2B, it actually invades the bladder or rectal wall, but not the inside. When the cancer spread to the lymph nodes in the pelvis or para-aortic lymph nodes, retroperitoneal lymph nodes, or peritoneal implants like a metastasis to the omentum or surface of the small bowel or liver, are categorized as stage 3. Stage 3A is the situation when the cancer spread to the retroperitoneal lymph nodes or to the omentum microscopically. In stage 2B, when the tumor spread to the peritoneal organs like omentum, but the tumor size is still less than 2 centimeters. If the tumor size in the peritoneal implants is over 2 centimeters, it's categorized as a stage 3C. Stage 4 is the metastasis to the distal organ, including malignant effusion. In case of malignant effusion, we stages as M1A, otherwise M1B. The metastasis to the distant lymph nodes, like inguinal lymph nodes, axillary lymph nodes, are categorized as stage M1B. Now, an experienced gynecologic oncologist do the surgery, removing and resecting ovarian tumor as much as he or she can. The optimal cytoreduction is to resect tumors achieving residual disease less than 1 centimeter each. But not every patient can have optimal cytoreduction. For example, if they have extensive disease like stage 4 with large ascites, peritoneal carcinomatosis, suprarenal lymph node metastasis, bulky disease in upper abdomen, or diaphragmatic involvement. How can we determine whether patients can have optimal site reduction or not, usually with the imaging studies, CT scan or MRI. But sometimes diagnostic laparotomy may be necessary to determine the optimal site reduction is possible or not. Those patients who cannot have this site reduction need to have a neoadjuvant chemotherapy, which means you give chemotherapy before surgery, shrinking that tumor so the surgery can be done later. I will discuss more in detail in next following slides. The cytoreductive surgery means not in addition to removing that uterus or ovarian fallopian tubes, but also may involve the partial resection or total removal of bowels, appendix, gallbladder, bladder, stomach, spleen, liver, pancreas, stripping of diaphragm or peritoneal surfaces. So this cytoreductive surgery can be quite extensive, resulting in significant morbidity or complication. So that's why the neoadjuvant therapy is getting popular. After the surgery is done, patients often need to have an adjuvant chemotherapy. The indications are stage 1C, stage 2, and of course stage 3. Also, patients with a clear cell subtypes or tumor with a high grade regardless of their subtype benefit this adjuvant chemotherapy. Usually we use carboplatin and paclitaxel every 3 weeks for 6 cycles. Recently, the intraperitoneal chemotherapy received some spotlights. Intraperitoneal chemotherapy involves that chemotherapy directly infused into the peritoneal cavity through the small catheter placed in the abdomen. In the beginning, it was very promising, but subsequent studies showed no difference between intravenous or intraperitoneal chemotherapy. Hyperthermic intraperitoneal chemotherapy during that surgery showed some interesting results, but most recent studies show the not real benefits. Bevacizumab is often added to the chemotherapy, especially when they have a high risk disease like a malignant situs or stage 4 disease. Dose-dense chemotherapy, which means you give a carboplatin and the paclitaxel every week instead of every 3 weeks. A Japanese study showed the very promising results, improving the survival significantly, but other study didn't show much difference. As I mentioned in the previous slides, the neoadjuvant chemotherapy is the preoperative therapy. Like initial cytoreductive surgery is not feasible, then what can you do? You have to give a chemotherapy first, followed by interval cytoreductive surgery. Usually we give 3 cycles of carboplatin and paclitaxel with bevacizumab for high-risk patients with a malignant ascites or perfusion or stage 4 disease. Then patients have interval debulking surgery, followed by 3 to 6 more cycles of chemotherapy. This neoadjuvant chemotherapy reduces the complication rates of upfront cytoreductive surgery without compromising the survival or progression-free survivals. So it's getting much more popular now. After all this treatment, surgery, chemotherapy, then we have to evaluate patients with the history of physical, check the CA 1 to 5 and CT scan of the chest, abdomen, pelvis. If they responded well, then when the patients have early stage of disease, stage 1 or 2, then that's it. They don't need to have any further treatment. But for advanced disease, maintenance therapy is indicated when the patients achieve complete or partial remission. For BRCA mutation positive patients, or HRD, meaning homologous recombination deficiency tumor, PARP inhibitor with the olaparib improve the progression-free survivals. Bevacizumab may be added to olaparib for high-risk patients. When they have negative BRCA mutation, then bevacizumab monotherapy is indicated if it was used for adjuvant chemotherapy previously. If you don't know the patients have BRCA positive or negative, or even regardless of that BRCA status, niraparib for 3 years improved the progression-free survivals. PARP inhibitors can cause acute myeloid leukemia or myelodysplastic syndrome rarely, so it has to be discussed with the patient. What about just giving chemotherapy as a maintenance? It's of no value. Now, treatment of relapsed ovarian cancer. When the relapse occurs after 6 months from the last chemotherapy, then we consider that tumor is platinum sensitive. But if the relapse occurs within 6 months from the last chemo, then patients have platinum resistant tumor. For platinum sensitive disease, we still use the platinum, mainly carboplatin, with the paclitaxel or docetaxel or gemcitabine or pegylated liposomal doxorubicin. This chemotherapy usually combined with bevacizumab. For maintenance therapy for recurrent disease, after responding to the above these treatments, then we give olaparib or niraparib or leucoparib. Those are all PARP inhibitors. Or bevacizumab are all FDA approved. They improve the progression-free survival, but overall survival benefit is not 100% sure yet. For patients with a platinum-resistant relapsed ovarian cancer, a single agent with a paclitaxel, pegylated liposomal doxorubicin, or others is appropriate to use. Bevacizumab may be used as a monotherapy or combined with single agents, as described above, like here. Be careful, bevacizumab cannot be used when the patients have a history of bowel obstruction, because it causes bowel obstruction sometimes. Cisplatin and gemcitabine sometimes induce good results. 16% response and the 54% have a stable disease. For clear cell endometrioid or mucinous ovarian cancer, immunotherapy needs to be investigated after the microcellular instability test is done. Endocrine therapy for patients with little or no symptoms is appropriate. We use the tamoxifen, or when they have ER receptor positive, letrozole or fulvestrant. Interestingly, refractory ascites, low-dose intraperitoneal bevacizumab helps. When the patients have a rising CA-125 levels only, without clinically or radiologically showing any signs of recurrence, surveillance is most appropriate until the patients develop objective evidence of disease progression or symptoms. Sometimes endocrine therapy may be offered. 5-year survival rate for stage 1 disease is 81%, stage 2 67%, stage 3 40%, stage 4, 33%. But this statistics is 20 years old. I'm 100% sure the patient now have a much better prognosis. This photo I took in Hawaii showed the bright sky and the ocean. And I see this light. I wish all the cancer patients have this hope, the light of hope. Thank you for watching.